Hey everyone. Today we're going to work and put together all of the information that we've been learning over the past few weeks. I'm just going to tell you that I'm at home and there are dogs and a cat that seems to really love to come in when I'm recording, and there's kids here. So we're hoping they're all going to behave for a little bit while we go through this, but there's no guarantee. Life is just full of fun adventures sometimes. Um, I want to put this together in a fun way because I feel like when it comes to ventilators and respiratory, we can get really serious and really intense. And so I think it's really important to remember to have fun as we're learning and to really stretch our own imagination and thought process. So what we're going to do is I want you to go to your local junk drawer or whatever, dig through it and grab out your deck of cards. At least that's where I usually keep mine. If you've got a game closet, whatever, grab a deck of cards. If you don't have cards, grab some scratch paper and rip it into 4 pieces. Because in the end, what I want you to do is I want you to grab 4 of a kind. So if you're going for queens, you've got all 4 suits for the queens. If you want kings, if you think you're an ace, great. I second that, you're awesome. But whatever it is, grab it. And you want to make sure you have all 4 suits because each one of these is going to represent a patient that I'm going to give you data for. And as we collect that data, you're going to be putting them in order of priority. So if you need to, pause this video for a second, go grab your cards, and I'll meet you back on the game board that I've designed. So we'll get there here. Okay. So this is our game board that we've got designed. And I'm going to introduce you to your 4 patients. So we're going to start with, we've got Stephen Spade, and he is an 18-year-old. And he unfortunately had a motor vehicle accident 2 years ago. So it's not a new accident, but it's 2 years ago where he had a C4 fracture. All right. He is now currently has a trach and is at your facility. We're going to go over to Kathy Clubb here. And Kathy is a 42-year-old, and she has a history of MS with, lately she's been having some recurrent aspiration pneumonia. Oops, that's okay. Oh, dang it. Well, my pencil wants to delete stuff. All right, so she's had some recurrent aspiration pneumonia. We have Harvey Heart. And Harvey has a trach. Oh yeah, sorry, Kathy has a trach too. Spoiler alert, they all have trachs. Harvey has a trach, but it's because of his obstructive sleep apnea, which is worsened because he's also unfortunately morbidly obese. You don't have to be obese to have sleep apnea, but it is, they seem to go together frequently. So he's on CPAP at night through his trach. And then we have Dina Diamond. And Dina is a 6-year-old, and she has a history of cystic fibrosis, and she also has a trach. And so what I want you to think about, and I'll put in here real quick just to add a little bit more data for you, what each one of them is actually in the hospital for. So we're going to say that you are currently working in a rural hospital environment, so you get a nice mix of patients, and you currently can't ship any of these patients out. They're all in care with you guys. And so it's kind of a swing bed facility. So you're going to see that you've got some mix of patients. So you have Stephen, and he is admitted for a spontaneous pneumo. Okay, so he has a spontaneous pneumo. Not going to, but a spontaneous pneumo, and is in for that. Kathy Clubb, she is unfortunately back in because of her aspiration pneumonia. So she is admitted again for some aspiration pneumonia. Harvey Heart, dang it, he has influenza type A. So he's in for that. And Dina, she's actually in for respite care. Her parents needed some time off for whatever reason, going to a wedding or something, and they just needed someone to watch her to take a little of their load off. So what I want you to do is I want you to grab your cards that you have, and I want you to put them in order. Here's the question, because you're asking in order for what? I want you to put them in order of who gets the ventilator? Which one of these patients would get the vent? When it comes to things like this, you're in a small town facility, you may not have access to a lot of resources and technology. So who gets the ventilator? Which one of these patients are you going to prioritize as getting the ventilator? So I want you to take some time, look through your notes. Who is your one that you're going to give the ventilator to? As you're working through this, we've got some questions over here to help you evaluate and think through it. What data do you have? Of that data, what data is important? What data do you still want? What questions are you pondering? And then think about who is your priority and why. What is your defense? What is your supporting data for that patient? Who are you really thinking you need to give some serious thought to or some serious care to? Do you have them in order? Who did you give the vent to? Are you giving it to Stephen? Are you giving it to Dina? What about Kathy? And what about Harvey? Put out your cards in order of who's going to get the ventilator first, and then we'll keep going on our activity. So a card game wouldn't be any fun if we didn't draw a card. The other thing I want to say is if you don't know what any of these things are, like a spontaneous pneumo or influenza A or MS or even cystic fibrosis, this would be a good time also to pause the video and look that up. Make sure you know what's going on with those patients. And then when you're looking up that information, think about what is your priority with that information. So, but like I was saying, any good card game is not a good card game if we don't have cards to play. So we're gonna draw a card, and that's how many pieces of data we're gonna add to these case studies, okay? So let's go with, we got a 5 of spades. So that means we're gonna add 5 pieces of data to these patients, and maybe that will help you decide who gets the ventilator just a little bit closer. All right. So let's kind of shrink this a smidge here. Okay, so we can write. All right, so 5 pieces of data. We already know why the patients are here. We already know a little bit about their history. So let's go ahead and go through and get everybody's vital signs, because that's what we would have at report. So with vital signs, so Kathy Club, her vital sign, she's got a temp of 101.4. She has a pulse of 98. She has a blood pressure, make sure I got the right one, 142/78. She has a respiratory rate of 32, and her oxygen is 89%. And what more information do I need to make that complete? She's 60% on trach mask. Okay, so there are her vital signs. Let's go over to Dina's vital signs. Dina's vital signs, she's got a temp of 96.3. She has a pulse of 120. She has a blood pressure of 82/43. She has a respiratory rate of 28. And she has, her oxygen saturation is 92%. And remember, we want to complete that with 10 liters on trach mask. All right, so there's Dina's vital signs. Now let's go to Stephen here. In Stephen's vital signs, let me find them on my paper. His temp is 98.6. His pulse is 68. His blood pressure is 96/60. His respiratory rate is 12. And his O2 sat is 96% on a 28% FiO2. Okay, so remember what that FiO2 means. And then we're going to go down to Harvey, and Harvey's vital signs, let's see, he has a temp of 102.4. He's got a pulse of 82. He has a blood pressure of 165/67. Let's see. He's got a respiratory of 22, and his oxygen is sitting at 94% room air. And since we drew a 5, that gives us 4 pieces of data. So we get one more piece of data that we want to pull together. So let's see, if we were going to add one more piece of data, let's go with Kathy's, let's go with her assessment. So her assessment, okay, I'm going to move the screen up just a smidge. So her assessment, and I'm really pretty much going to write down just the abnormals or just kind of some highlights. So she's alert and oriented ×3. So she's got crackles in the bilateral lowers. Okay. She uses a walker to ambulate, but she is weak ×4. Her heart is strong and regular. Her pulses are all palpable. So her pulses are palpable ×4. She does have some skin tinting. And let's see, anything else? Her abdomen's soft, active. She's pretty thin. Her peg tube is currently clamped because she just really gets bolus feedings. And there's no redness or swelling around it. So that peg tube site looks really nice and looks like she's pretty healthy. So now you have 5 new pieces of data here. Nope. There it goes. Now, take some time to evaluate. What data do you have? What of that data is really important? What pieces do you feel are valuable in making a decision of who gets the ventilator? Who needs it? What data do you still want? What are you itching to know? Who is your priority? So you've got 4 patients. Which one of these patients is currently your priority? And then why? Digging into that why will help you understand how you're picking the things you are. So who of these patients is your priority? Take some time. If you need to, pause this video at any point in time. I'm not going anywhere. So go ahead and look through and see who of these patients would you give the ventilator to? Are you giving the vent to Kathy Clubb? Are you giving it to Dina Diamond? Are you giving it to Stephen Spade? Or are you giving it to Harvey Heart? Which one of these patients would you get the ventilator to? All right, so we got to draw some more cards so we can get some more data because I'm sure there's more information that you're wanting to know. All right, our next card is a 4 of hearts. All right, oops, apparently I draw all my hearts. Okay, so we get 4 pieces of information with this one. So let's change my pen color. We started with, we already got 1 patient's assessment. So let's go ahead and finish out our assessments. So let's see. Harvey Heart, his assessment is, where is he on my stuff? So he's alert and oriented ×3. He's got wheezes. And then he's got some coarse bilateral uppers. And then he's diminished in the bases. Think about his physical structure. What would make that diminished in the bases? What would make it hard to potentially hear his bases? All right, of those lungs. How can you position him so that you could hear those better or with more clarity, so that you really knew if he was diminished or if it was just adipose tissue you're hearing from? He does have a strong cough that he's bringing some stuff up with. Let's see, he's got his trach is capped. Okay, and then he's pretty pale, and his pulses are kind of weak. So he's got weak pulses ×4. He doesn't really have edema, but it might be hard to tell if he's got edema or if he's just kind of fluffy with his adipose tissue. His abdomen is soft, but he is hypoactive with his bowel sounds ×4. So that's kind of his assessment. He's got the wheezes with some coarse bilaterally in the uppers, got those diminished lowers. He has a strong productive cough, but we're not really seeing anything come out, so we're not getting any colors necessarily. He's just kind of swallowing it. He does have the trach, but it's currently capped. He is pale, weak ×4, and then just edema. So just basically, he's just really not feeling well. All right, so let's talk about Stephen here. Let's talk about his assessment. What kind of assessment data would you be looking for with him? What would be some of your priority? Well, he's alert and oriented ×3. Okay, how are you going to assess that on him? How would you know if he's oriented? How would you potentially communicate with him? Remember, he's had a C4 fracture. But so he's diminished on the right sides. On that right side, he's clear on the left. So where do you think his spontaneous pneumo is? Helps if I spell it right? Where do you think that spontaneous pneumo is if he's diminished on that right side and clear on the left? He has a right spontaneous pneumo. All right. What is a pneumo? So when we've talked about this, I'm going to veer off just for a second because I know we haven't really talked a ton about chest tubes or any of this kind of stuff. Okay, so these are my really bad lungs because they are totally not even. So if we're looking at this gentleman and this is his left side and this is his right side, his pneumo is in his right side. Now, when we have a pneumothorax, that means we have air. If he had a hemothorax, that means it is blood. Now, it's really important. The main way we treat this is a chest tube. Okay. And I think there's some videos posted for you guys to look at about chest tubes. I'd make sure you look at those. They have a lot of valuable information. So this is a quick little recap of those information, but definitely not as full as what you're going to want to know. So when we're talking about a pneumothorax, that means we have air. What people often think is that chest tubes go into the lung. Oh, I meant to change my pen color. They go into the lung. Chest tubes do not actually go into the lung. They actually go around the lung. So, because we have a pleural sac. And so they really go into this space here. And they go around the lung so that we can get whatever it is in here out. Because when we collapse a lung, this is what's filling up, is this space. And if it's filling up here, like any gas, it's air, right? Air goes up. So a pneumothorax, the air would fill here, and that lung would start to collapse down, making that lung smaller and smaller and smaller. And if that lung kept getting smaller, eventually it would collapse fully and then it would start putting all that pressure and we'd start moving it over, which then you're compressing the heart that's under here, you're compressing the other lung, and then we have what's called tracheal deviation, and that's called a tension pneumo. That's really bad. If we get somebody to a tension pneumo, we've missed a lot of signs and symptoms and we've missed a lot of problems. So here I'm going to erase all this and I'll kind of redraw it so it's a little bit more clear. Okay, so we've got your lungs. Okay. And definitely drawing on a tablet is not my preferred media for artistry today. Come on, can we back? There we go. Okay, we've got the pleural sac that's around our lungs. And there's usually about 10 mLs or so of fluid in here. Remember, nothing happens in the body that's dry. He's got a right-sided, so meaning this side is filling with air. And that happens, spontaneous pneumos happen oftentimes in younger people just because they get growth spurts, or especially our long, skinny friends that are nice and tall. They'll have some pneumothoraxes pop up. And so we put in a chest tube. Okay. And then we go the chest tube. If the chest tube is up high, that's bringing out air. If the chest tube is down low, it's bringing out blood. So it really depends why they have the spontaneous pneumo, or the hemothorax and the pneumothorax. We've got to understand what's going on and why we have it. I'd make sure you understand words like titling. Just spell right, because that's important to understand. You look at the different areas of a chest tube, and you have water seals, you have suction, we have all sorts of things that come to a chest tube. But make sure you're watching those videos so that it helps you understand. But Stephen has a spontaneous pneumo, and so he's got a chest tube in place. So thinking about that, that is why you would have diminished right side, because there's just literally no sound in this space here where it's all filled with air. And it'd be clear on the left while he's still doing fine and breathing okay. So let's keep going on his assessment. Stephen has, he can shrug his shoulders, but he can't really talk to you, okay? He is on, has that trach. He has no real hand or arm control, but he can kind of shrug his shoulders and kind of move that way. His heart is strong and regular. Okay, his pulses are all really palpable, ×4. He has no edema. He has no leg movement, so he can shrug his shoulders, but nothing in his legs. He has no sensation in his legs. His abdomen is active, and he does have a Foley that is doing clear yellow drainage, and it's sufficient. So that's kind of our assessment on him. His chest tube site looks good. The dressing is clean, dry, and intact, and the chest tube is hooked up to suction. So he's got chest tube to suction, and there's no air leak, okay, which is important for us to understand and look for. Okay, so that's kind of our assessment on Stephen. Now let's move over to what is our assessment for Dina. And Dina is our 6-year-old, remember? She is alert, but she's nonverbal. Okay. She responds though with smiles. She's a cutie. She responds with smiles and interacts, but just can't really say any words. She has a G button, so she gets feedings at night. So she gets some nighttime feedings, because remember, in order to live, we need two things. We need that food and nutrition, and we also need breathing. But she's got her G button. Let's see, her abdomen's a little distended. And it's active ×4. She has gross motor movement of all extremities. So gross motor, times 4 for extremities, but no real fine dexterity or anything like that. She has no edema. And her heart is strong. It is irregular. She has an irregular rhythm, but it's strong, nice and loud, and you can hear it. Irregular rhythm, and her pulses are palpable times 4. So, and her lungs are kind of coarse. She needs frequent suctioning to get those thick secretions out. Okay. So what number did we pick? Oh, we had 4 of hearts. So that means we get one more piece of data. So let's just say that, well, it kind of gives us all of our data. Oh, we'll go with Dina is a full code. All right, so that gave us our 4 new pieces of data as we, oh, dang it, it likes to move stuff around on me, doesn't it? Come on, shrink. There we go. Technology is great when it works for you, right? Anyways, so that got us our 4 new pieces of data. How does that change your priority, or who is the priority? So what I want you to do, again, take time to evaluate. What data do you have? What data is actually important, and what can you just not worry about? What data do you want? What questions have been brewing in there? What are you thinking about? And then think about, who is your priority and why? Why did you pick that one to be your top? So spend a little time, go through your notes, circle the pieces of information that are important. Take the time. Like I said, I'm not really going anywhere. Feel free to pause me. But then take time to go through and look at the patients that you have, and which one are you going to give your give that ventilator to. All right, let's draw our last card and see what we got. So we got a 5 of spades, 7 of clubs. So here's our, see if I can make it bigger so, yeah, well, crooked works. All right. Oh, technology today. Okay, so quit. Oops, sorry guys. Okay, so we got a 7 of clubs, which means we can pretty much finish out all the information we need on these patients to be able to make some choices or have some more discussion. So let's switch us to black. I'm going to switch my pen, make it a little bit smaller so it's not writing. Ooh, I can do a light blue too. Oh, so many colors. All right, so what we're going to do is we're going to go through with 7 pieces of data. Let's go, let's finish out getting everybody's code status. So Harvey Heart, he is also a full code. Stephen Spade, he is actually a DNR. Okay, and then Kathy Clubb is also a DNR. Now, I want you to take some time. What does DNR mean? DNR means do not resuscitate. It does not mean do not treat. So we can still treat people that are DNRs. Sometimes that gets confused or thought of. The other thing to think about is where you live. Different ages can sign consents or legal documents at different times. Stephen Spade is 18. Is he able to actually sign a DNR at this time, or would he have had to get the agreements of his parents? The other thing I want you to think about is, at what time can someone make a decision about their medical care? How old is old enough to understand it and to make those choices? You've got Harvey Heart, who's a full code. He is obviously old enough to make his own choices. So, we'll go from thinking about that. Kathy Clubb, she's 42. She can make her own choices. But then you have Dina Diamond, who's 6 years old, nonverbal. Do you think she's at a spot where she can make her own choices and she's a full code? Do you think a full code is a good thing for a patient with cystic fibrosis? Just things to think about as you're working with these patients and understanding their code status. How would it change with Kathy Clubb if she had ALS versus MS? Does the disease change how or where their code status should be? Or what priorities do you have when it comes to code status? So the last pieces of information that we need to think about are their vent settings, or what kind of oxygenation settings they're on. So for Kathy Clubb, you've got her on trach mask. She's 60%. But that 60% FiO2 on that trach mask is not doing a whole lot of good for her right now, right? That 89% is probably not super great. Okay, so she's on trach mask, so she is actually not currently on a vent, right? Harvey Heart, he is also currently not on the vent because it's not nighttime, but at nighttime he's going to be on some sort of positive airway pressure. Positive pressure. So what does that make you have to understand? Is this our PEEP support, our positive airway pressure? So thinking about what kind of PEEP setting would he be at? And he's on some sort of CPAP at night, but not during the day. Okay, and a lot of times ventilators can act as CPAP machines or BiPAP machines, or so that's something to keep in mind as well if we have to do some finagling with machines. We've got Stephen Spade, and he is currently on a pressure control on the ventilator. Okay, and his rate, I'm kind of zoom in here, see if I can. His rate is 12, and his FiO2 is 28%. So something to think about with him is his rate's at 12. So if his rate's at 12 and he's breathing at 12, is he breathing over the vent? Or is the vent having to breathe and take every breath for him? So this is, even though he's a C4 injury, he obviously needs all of that ability. The vent is doing all of the work for him, and he is not doing it on his own. So sometimes a C4 injury can kind of get a little wiggle room, depending on the level of injury, or how severed the spinal cord is. Remember, it's just got to have that communication go from the brain to the diaphragm and back and forth. And if he has some of it, that might alter what he can do. But if you have one ventilator and you've got Stephen Spade, who's an 18-year-old, but a quad, what kinds of conversations would you maybe want to have with him regarding his status and where he is in understanding his injury and level of injury? Is that a spot for the nurse, or is that only what doctors can do? So something to kind of think about when you're working with Stephen here. When it comes to Dina, she's got cystic fibrosis. How is that going to change your care for her with cystic fibrosis? Is this a disease or an illness that she's going to get over, or is this something that's going to continue? If you looked at her vitals and you evaluated them, I'm hoping this caught your attention a little bit, but we have to remember is vital signs are different for kids. Now, 82/43 for a 6-year-old is probably relatively normal, and so we're probably okay with that. Something I'm not okay with is I'm really not okay with this. 92% on 10 liters trach mask. When it comes to kids, where do we want their O2 sat? You never want their O2 sat less than 95. Less than 95 for a kid is considered bad. And so we want to make sure that they are always above that when it comes to oxygenation. Where she's 92%, that means we've got some extensive problems going on, whether she's got the thick secretions and we need to suction her out, or we need to increase her oxygen. Something needs to happen with this little girl to get her breathing better, potentially putting her on a ventilator for to keep her going, you know, because she does have a trach, so we have that ability to put her on a ventilator pretty easily. So that's something to think about as you're working. If you change and work with kids, their numbers are different, and that becomes really important because we may have to adjust our care and our knowledge based on the age of the child. So like an 18-year-old, not so different in their numbers, but definitely a 6-year-old has different numbers. Let's talk about Kathy Clubb here for a minute. We've got something going on with her oxygen. She's on trach mask. She's on a lot of oxygen via that trach mask, but she's only 89%. She's breathing a rapid rate. We've got somewhat of a temp climbing. Blood pressure maybe showing that she's working really hard. Her heart rate's up there in the 90s. So her vital signs alone show me that she's not handling this low oxygenation really well, and we probably need to do something for her. What kinds of orders would you think of for some of these patients? So if we're talking about orders, let's talk about, let's see if I can change my color here. Talking about orders, maybe I want to get some better O2 orders for her. Maybe I want to see if we can adjust her, get her on some BiPAP, some sort of pressure support to help open up that airway. I'd want to make sure there's some antibiotics on board for her. With this aspiration pneumonia, it sounds like she's kind of thin and not doing so well. So maybe we need some fluids because we do worry about sepsis or any of those kinds of issues. So something to think about with her is definitely need some more O2 because this is not cutting it for her, and we need to get her up a little bit more. But we probably also need to have some sort of conversation with her or her family of, you know, if this is recurrent, how many times has this been? Is this her 5th time in the hospital in the last 6 months with aspiration pneumonia? Have we lost that much of our swallow that, you know, and is this the route she wants to keep going? But definitely looking at some extra pressure into that airway, antibiotics to get her opened up, some fluids. Maybe we're going to do some steroids because maybe the steroids would be a double dip here because our steroids bring down that inflammatory response, but they also bring down the immune response, which MS is an autoimmune disorder. So our steroids might actually really help her and get her doing better. For this, maybe some albuterol to get her opened up, and then some longer acting Advair or Symbicort, something like that to get her opened up, to get those lungs working better for her. Let's go back up to Dina because we really didn't hit on some orders that we might want to call the doctor about or to make sure we have. She's got really thick secretions, so maybe we want to get some guaifenesin or some sort of mucolytic expectorant to get it in there and get that stuff broken up. Maybe we want to get some orders for her O2, see what range are they wanting to keep her at. Every once in a while you'll get a kiddo that they do keep low, not very often. So that's something we want to make sure we verify. What orders do we have for our O2? Where's our range that we want to keep them? That blood pressure, like I said, is probably okay. That temp's a little interesting. It's a little low. I might have to recheck that and make sure that was an accurate temp and not just oh, they took it and she wasn't really paying attention. Again, might also do some albuterol to get those lungs opened up, and we might also do some longer Symbicort or and then maybe some steroids to help her if she's got some inflammation. But this is more cystic fibrosis, is more of a thick secretion issue, and the lungs kind of getting hard and not as pliable. So I'm not sure how much the steroids would help, but they might. She's got an irregular heart rate. Not totally sure where that's coming from. Maybe want to check and see Maybe it's just because it's going at 120 and that's just a little fast for a kid, but not super out of range, especially for a kiddo that's got a struggle to breathe kind of issue. Let's talk about Stephen Spade. What kind of orders would we want for him? Okay, I mean, definitely we need some vent setting orders, which it looks like we kind of got if we've got our rate and our FiO2 and that he's on pressure control, which means that it's breathing for him. So we've got our vent orders. We'd probably want our orders for our chest tube. I don't know about you, I'd probably want some x-ray orders, some chest x-rays, to see if that space is getting better or if it's getting worse or if there's something else we need to do. I mean, you're not necessarily going to do steroids because the issue is not inside the lung, right? In this one, the issue is more outside the lung. It's in this pleural space that is where stuff is building up. So steroids, albuterol really aren't going to do you a whole heck of a lot of good because of where the problem is located. It doesn't mean he won't have breathing treatments. It just depends. He might have breathing treatments that are just his long-standing orders. And then let's talk about Harvey Heart. This gentleman, he's got influenza, so I mean, we probably want to get something going. Might need some antibiotics or some antivirals for him. Might need something, he's got a temp, might need to get some Tylenol on board. Anybody else concerned about this blood pressure or looking at it relatively like, that's interesting? Well, hopefully he's just has chronic hypertension, but that would be something I'd want to clarify. Do we need to get some low pressure or some medications to bring down, ooh, that's way badly written, sorry guys. Some low pressure or something, metoprolol, something like that to bring down that blood pressure, or are we okay with his blood pressures being there? So we would probably want some sort of range. Are we going to take the ventilator away from, because our one vent sounds like it's on, is on Stephen Spade. So are we going to take our ventilator away from Stephen Spade to give it to one of these guys? Or are you going to let, keeps just wanting to do stuff. Are we going to just let Stephen Spade keep having it? That becomes really challenging. What if I told you that Harvey Heart, his family, they bought the ventilator for your town, and you're going to tell him that overnight he can't have that ventilator? That becomes really challenging. I know people think that this is a really weird activity and it would never happen, but there are certain times when this happens. Global pandemics, natural disasters, those are times when we have to make choices sometimes in the medical field. And it's really scary and really sad. And it's like, who gets to make those choices? And sometimes those choices have to be made really fast. So if you're twitching and itching for who got the ventilator, you tell me, because I don't necessarily know. There's not necessarily a right or wrong answer to this. You have a 6-year-old so does age play a role in that? You've got a 6-year-old and an 18-year-old. So if you go for youth, if youth is how you make your decision, then the 6-year-old gets it. But then if you look at prognosis, well, Kathy looks like she's getting close to the end of her MS. Dina could be getting to the end of her cystic fibrosis illness, and maybe she's not on that lung transplant list. Maybe the family doesn't want her there. Harvey, like, yeah, he's okay, but I mean, if he stops breathing in the middle of the night, he's going to definitely have some pretty significant struggles. And if you take Stephen Spade off the ventilator, he is going to die. He is breathing right along with the ventilator. He doesn't overbreathe the vent. I know it sounds really cruel. I have had situations like Stephen Spade where we have taken people off the ventilator. They were fully competent. They knew what they were doing. They had made the decision. It is a really emotional and a hard process to be in. But remember, as a nurse, our job is to not only understand the science behind each one of these disease processes and understand the pharmacology of the drugs that we're giving them and understand the emotional capacities that are going on and challenges that these patients are having. But it's also to be a patient advocate and to always use our voice as the patient's voice. Remember, this is their journey, not yours. You may not agree with their choices, but that doesn't mean that you don't advocate for them. So when you're working with patients like these, which you'll have all of these different kinds of patients at different times in your life. So they definitely won't have these names. And if they do, well, I'm a future teller, but most likely they won't have these names. But you will have some of these patients, and you will have times when these patients need to have decisions made for them, whether it be calling the doctor to get more orders, or it be working with their family, or it be simply holding their hand while they cry and tell you how scared they are. So think about, what is your role as you care for each one of these patients? What was the important information? What information do you need to be able to make those decisions? And is there information I didn't cover that you want more, that you want to dig into more so that you understand that patient condition more? That's us. That's us digging in and digging into that information. Hope this helped you kind of put this unit together, and I'll see you in lab.